the anatomy of the colon, this is something else we've known. For example, gastroenterologists for years have described these flat, serrated polyps in the right side of the colon, not on the left side, in the right side. Well, they're biologically different. I think the main thing we have to realize is that it's not a uniform population of cancer cells. For the moment, what I believe in studies, for example, we'll have to say studies will put patients with right-sided cancer in one study, patients with left-sided cancer in another. I hope that isn't for too long, though, because I would assume we will figure out what the features of the right and left side are that are dictating outcomes. I think anatomically there's other ramifications. It's been fascinating. There's been an argument, certainly in some health providing organizations, about doing sigmoidoscopy or colonoscopy. When we've now clearly shown that right-sided colon cancer is just different than left-sided colon cancer, how in the world would you only do a sigmoidoscopy? Because they're just different. They're different entities. It makes no sense to me. It's like doing a right mammogram and not a left mammogram, because looking at the left colon doesn't tell you anything about the right colon. I don't know if that'll have ramifications there, but it should. And again, and then the other thing I believe is our approach in terms of our goals of therapy may now be very different. Patients with right-sided cancer may be a much heavier lift to be able to cure them, given their innate prognosis. And so these are all factors that will go in. Doesn't mean that I'll do something dramatically different for the patient who shows up on this Wednesday, but I'll be thinking of it. As one of my colleagues says, I'll think of RAS, RAF, MSI, and SIDE. And hopefully at some point we'll figure out SIDE, what it represents. Do we test patients with right-sided cancers? Why would we do that if we're not going to use the cetuximab? Good question. And I think right now I'm not sold on knowing all the answers on the right side, so I would still check. There was one observation in our study which is really hard for me to understand. It absolutely twists us up into a pretzel. And that is, in the study, because we had a pre-amendment group of patients who received cetuximab, even though they were RAS mutant, remember, we didn't know that, we shouldn't be doing that. We had a couple hundred patients who we were able to analyze in terms of right versus left side. And so if you follow this, patients with RAS mutations and right-sided cancers live 23 months. Patients with RAS wild type getting cetuximab on the right side lived 16 months. So the patients who should not be getting cetuximab lived almost 7 months longer than the patients we would give cetuximab to. Makes no sense and really tells us we don't really understand RAS very well. But that's an idea, that gives you a handle on sort of how we have to look at the disease now. A lot of the things we thought we knew, we don't know. And in many ways, it's almost back to the drawing board, because we get into trouble, I think, when we have biases and we think we know what we're doing. In fact, it's a humbling process to figure out that maybe we don't know what we're doing. For this, though, we're hoping to put together a big international consortium, put all of our data together, and see if we can't really get clarity by doing that as well. And we're in the process of doing that. So the most important data set, a couple of important data sets, Crystal, which is FOLFIRI with or without cetuximab in KRAS wild-type patients, very important. I would expect, I believe we'll see that the benefit to cetuximab in that study accrues only to people with left-sided disease. That would be confirmatory of our observation. PEAK is another study that compared bevacizumab to panitumumab. That will be important. As I said, the Volker Heinemann and I have already agreed to combine our data. Then there's some older studies, COIN and OPUS. A lot of them may not help us very much. Again, none of these studies captured the side of the primary in the beginning. Pretty inept, I guess, when you think about it. But so part of this is how much effort can we put in to try to figure that out. But those are the imperative data sets. And what our next studies are going to look like, I don't know. We really don't know. I don't believe we should be planning studies until we have a better handle on this, because I hate to start a study and then have to stop it midway when we say, duh, we should have done it something else.